So I'm Sarah. To start off my BE trigger, what I would first do is I would go and greet my patient. I would have them go and change and introduce myself, and I would double ID them, check to see if they're pregnant, and make sure that they prepared for the exam properly, see if they fasted, and then once they've changed, I'd have them come and wait outside the room while I just get everything prepped and ready to go and get out all my supplies and mix the barium and all of that, and then we'd get started. And in preparation for the exam, it's a really good idea to lock the bathroom so that somebody from the outside can't come in when your patients need to use it. And then at that point, you would be ready to start. Okay, so a couple of things that you need to set up your exam. You need the barium and the tubing and the tip. It's also a good idea to have extra towels set out for your patient when the exam is done, and to have some hemostat and gloves. It's a good idea to put on 2 pairs of gloves so that if there's a mess, it's easier to just take off the top layer of gloves than trying to put on another layer of gloves later. So those are all the things that you really need for the exam. Filling up my barium enema bag. You can fill it to different levels depending on if you are needing a thicker or thinner barium, but typically 500 ml is enough of water. So I have my clamp on the tubing, nice and secure so it doesn't leak out the other end. And I'm gonna open up this seal and start filling it with water. If I can get it to open. Okay, so the water line's right about at the 500 ml line. So I'm going to close this up, making sure that the seal is nice and secure. And then I'm going to poke out these holes here, and I'm going to give the bag a really good shake. Okay, trying to get out any other extra little bit. Okay, and since it's and then this part one here, you have to push out of the tubing. Okay, oh there we go. Okay, got it. So once you push the red ball out, you'll see that the barium will start to flow. I do have it locked, so it's not going to go everywhere. This is going to be hung up on an IV pole, 24 inches above the patient's penis. Okay, there we go. It's a good idea to set out some sterile lubricant, have that out for when the radiologist is ready. And at this point, what I'm going to do is I have a trash can, and I'm just going to let out some of this into the trash can to get out all the air. I'm going to bleed the line and clamp it off. There we go. And now we're ready to go. Yeah. Okay, so we found the correct type of tip. This is a double lumen tip. It allows us to inflate the balloon with this cuff inflator here. And you want to make sure that you test this before you use it on a patient. So when you're setting up for your exam, you just take one squeeze, and that's going to administer 90 ml of air into the balloon. And then you're going to clamp it to make sure, that it inflates. There might be a hole in mine. Let me try that again. So you're going to give it a squeeze, and make sure you get it all the way nice and tight. So here's an example where you check it. This one is slowly deflating. But that's the purpose of this. And then this is the air infuser here, this bowl. On some tips, there's another line here where you can connect this one. This one doesn't have it, so it only allows for the balloon to be inflated. And when it comes time to uninflate the balloon, all you have to do, you can do the clamp, but the easiest thing is to just pull it right off, and it's going to deflate. And then these, of course, is a hemostat. All right, so now that I have my whole room set up and I've introduced myself to my patient and they're done changing, I'm going to invite my patient into the room, and I'm going to start by taking a scout image, which is a lot like a KUB. And then from there, I'll explain the procedure of the whole barium enema. So you can come on in. This is my patient, Sky. And Sky, I want you to come right up here on the table. I want you to lay on your back with me up at the ceiling. Okay. Got my chair in place. Move the stool. And I'm going to have you put your hands on your side. Move this on over. And I'm going to have it detented. And we're at 40. my patient down this way. So I'm centered on her iliac crest, right there. And then we go for the bladder. Here we go. And I'm just going to make sure that I have her nice and centered, which I do. Mark her on here. It's probably best, since we're trying to get her entire colon, to put this down in this area here, marking her right side, so we don't overlap any important anatomy. And then I'm going to shield my patient. So, and make sure that my Bucky is in line. Perfect. Okay. So then I'm ready to go for a regular KUB without any contrast. I would probably do 75 kVp at maybe 18 mass, just a little bit lower. Once we add the barium, the density does go up. So I'm going to ask you to take a big deep breath in, blow out all your air, hold it out, out, breathe. Okay, so that would take care of my scalp image. So then going in from there is when we would introduce the barium. So I would explain to my patient that you will feel some pressure when this is inserted into the rectum, and then again when the balloon is inflated. So I'm going to have you go ahead and roll onto your left side. Watch your head there. And actually, if you could lift up your shoulder, I'm going to slide the shield under you. There you go. My shield is there. And I want you to bring this knee forward. There we go. So now I have my patient in the Sims position. It's important when you insert the tip into the patient that you make sure that you insert it about 1 inch to 1.5 inches anteriorly and then superiorly, and that you do not insert it more than 4 inches. It's usually best if the radiologist does this part. So I'm going to go ahead and simulate that. So it's also important to have them take a big breath in and blow their air out, and then take another deep breath in, and on the exhale, then you're going to insert the tip into place. So go ahead and take a big deep breath in, blow out all your air, another big deep breath in, and exhale, we're going in. There we go, I've inserted the tip into my patient. I'm going to inflate the cup at that point, and that would hold it in place, and she would be ready for the radiologist. So when the radiologist takes over, they would stay in the Sims position, and the barium would be allowed to flow in all the way up to the left colic flexure. And then at that point, once it's reached there, you'll take the barium bag down, so that is enough barium. You'll clamp it again, and you'll rest it here at the foot of the table. And I think this is the point where you put the forceps on the bag. And they're there, and then at that point, you're going to roll your patient into the right lateral decubitus position, which will then be the position that they're in for the AP projection. We're looking at the lateral side of the ascending colon, and we'll be looking at the medial side of the descending colon, just for how the barium falls. Go ahead and roll onto your right side now, if you can. Okay, roll onto your right side, up the bag. Okay. There we go. Take your knees, we're going to stack them there. There we go. Good. Bring your arm up this way. Watch your head. All right. So now I'm going to remove the IR. I'm going to run this one and get a new clean one. Never have to do this one yet. Slide it in. Here. Okay. Now, I want you to, if you can, carefully scoot back a little bit. We're just going to try to decrease the OID if we can. Okay, a little bit there. Good. There is some of a gap, but I'm worried about my IR falling. So, ideally, you want to have your patient as close to there as you can. Alright, for 42 inches, I'm going to take that. to see what I've done. There we go. We've got it to the midline here, and I'm gonna bring the tube down just a bit because we want it centered to her chest. There we go. Midline of the body. Press. Okay. So now with their barium, I have to up my technique. So for this one, I would probably use about 80 CVP at about 20 mass. And I'm going to put my marker on here. Her left side is up, so I'm going to use my left marker above her here. I'm going to put it backwards for stop points. There we go. And I'm going to ask my patient to suspend respiration, so please hold your breath. Expose. And so that takes care of my AP projection, the right lateral decubitus position. So then we're going to move into the lateral while she's there. And so then I'm going to take this plate, I'm going to run it, get a new clean plate. Take my marker and put this into the bucket vertically. Combination's happy. So I'm going to send it to my right at the crest there, and I'm going to put my right marker now in front here. There we go. Give you a good look. Trudy. Whoop, dropped everything. And we're going this way. Let's see. You see that? Hi, Sky. Okay. So there we go. For this one, since there is more mass to go through, I'm going to bump it up and say about 85 kVp at about 20 mass. So go ahead and hold. Nope. Go ahead and hold. Actually, make sure good. Okay. Feeling my patient's face. Hold your breath and expose. Okay. So that would be my lateral. And then what I'm going to do is my PA oblique projection of her while she's in the REO position. So Sky, what I want you to do now is roll onto your stomach. There you go, all the way onto your stomach. And then I want you to put your right arm all the way down to your side like you're reaching in your pocket. And this one, go keep that one up and bring this knee up just a bit. There we go. But this is going to give her a little bit of an incline. It's going to give about a 35 to 45 degree rotation. It's a little baby underneath. But it looks like you're kind of twisting your body up. Bring this hip forward a little bit. Yeah, there you go. And we're going to bring this leg down just a bit. Good. That's a good oblique. So now, what we're going to do is for this one, we're going to, the central ray is perpendicular, and it's going to enter about 1.5 inches or about 1 inch to 2 inches lateral to the midline, entering on the elevated side. So I've got her, can't see her spine, about 2 inches over lateral, so that looks good. But it's going to be at the level of the iliac crest, and her crest is right here. So we're going to go just a bit higher again. There we go. Oh, it's reloading me. Okay. Right there. So then I'm going to take my my marker and I'm going to put this right there, far in the corner as I possibly can, away from everything. Okay, for this one, since she's in an REO, again, we're going to bump up the technique just a little bit. So I'll probably do 90 kVp at about 20 mass. So again, I want you to take your breath in and hold it, expose, and breathe. Great. Okay. So now that that's in a new one, and the next that we're going to do will be in the prone position. So I'm going to have her lay all the way onto her stomach. So now that she's prone, I can do my PA projection. This one is going to enter perpendicular again at the mid-sagittal plane at the level of the iliac crest. So we're just gonna, can you put your, let's see, you're kind of rotated a little bit. There we go, sorry. Here's your spine here, and perfect crest right there. So we're gonna, midline, just checking that I'm all lined up. Great, so from here, I'm gonna do my left one again. Left. And okay, so this one, since she's not at any angle, I can go a little bit lower on KVP. Maybe I would do like 87 KVP at about 20 mass. So we have a shield on rotation. So Sky, will you go ahead and take a breath in and hold the breath, expose. All right, so that one's good. Okay. So now that that one's done, it's for the PA axial, so I'm gonna change that one, put in a new one. And all right, so now that she is in the prone position, I'm going to be shooting a PA axial projection. This shows the rectosigmoid area of the colon best because of the angulation of the tube. So 30 degrees on it. So since she's tinier, I'm going to go right to about 30 degrees. So I'm accommodated to a 14 by 17. All right, so I've got her prone. I've got the 30 degrees plotted angle on here. And we're lined up with our crosshairs to level over as is. And I've got my laser light agreeing with my flashes. So we're all lined up. For this projection, I would probably use about 85 at 20 kVp because of the angle, making just bringing the tube a little bit farther away. I'm going to make sure I put my marker up here. Okay, so I want you to hold your breath, Sky, expose, and then I would change out my IR, take it out, put in a new one. So now we're going to move on and put her into an LEO position. What I want you to do now, Sky, for LEO, is I want you to drop your left arm down. Oops, sorry. This one down at your side, like you're reaching in your pocket. Then I want you to bring that knee up, like what is it, all right. So again, for the oblique, now she's in the LEO. Again, it's going to be that 35 to 45 degree rotation of her body. The CR is perpendicular. It's going to enter 1 inch to 2 inches laterally from the midline on the elevated side. So her spine is right up here, and that's a little bit too far. So actually, sorry, go the other way. Go away from me. Get away from me. Okay, there we go. Okay, so her spine's right up there. There we go. So we're going to enter about there. This out of the way. And my marker, I put right here. I'm going to mark this side of her, because I mark the other side a lot. But I'm going to do that side. Okay, so for this one, since it's an RIO, we're going to bump it up to about 90 kVp at about 20 mass. So go ahead and hold your breath, expose, and breathe. So I'm going to have her go into a left lateral decubitus at this point. So do so now. I want you to go all the way up onto your left side. Bring that posture. Okay, so now that she is in this position, I'm going to run that last cassette, and I'm going to put a clean one in. Should be so much easier than the other one. Okay, so I have my new cassette. What I'm going to do is this way, 14 by 17. We're going to line up to the mid-coronal plane at the level of the as-is. This is her crest. So we're going to go to about here. So, yeah, so let's see. We've got her at the low of the azes, center to the mid-coronal plane, with a marker behind her here. She has lateral, so we're going to do about 90 kVp at 20 mass for this one. So, my shield on here. And I want you to go ahead and hold your breath, expose. I'm going to take out that plate and run it. Okay, so I'm going to do my PA. I've got my horizontal beam that's perpendicular. My IR is going to enter at the mid-sagittal plane and at the iliac crest. So here's your crest. And actually really good. So I've got it right on there. So I'm just going to show you, bring this over. You can see there. And she feels shielded. Somebody go on top. Sorry. Okay, there we go. Okay, well, I'm going to put my right marker on to demonstrate that the right marker is up. I'm going to put it on backwards for style points. There we go. And since she, yeah, let's see, we're going to drop the KVP down again to about 85, and we'll shoot 85 at 20. Go ahead and hold your breath. Expose. All right, I'm going to run that IR and so now I'm going to just do the lateral rectum to finish off this exam. That is going to be shot perpendicular to the mid-coronal plane at the level of the azes. I'm going to come down quite a bit to make the dose. Patient's nice and lateral. Okay, so here we go. This is her crest. We're going to go it's a little bit below that, which is great. We're going to be centering to her mid-coronal plane, so we're going to go. Okay, can you scoot back just a little bit towards me? Sorry to have you scoot and move so much. Thank you. There we go. Mid-coronal plane. Here's your crest. It's about the level of her azes. So now we're going to come down. So I would actually put in an 8 by 10 for this one. So I'm just going to come down to what my light would be. 8 by. Okay. I'm going to use my left marker. I'm going to mark her right here on the upper corner. As far away from everything as I possibly can be. All right, for this lateral, I'm going to use about, going through all that bone. I'm going to actually go to about 95 kVp, and I'm going to drop my mass a little bit to, well, that doesn't make sense. I'm going to use 95 kVp at about 25 mass with all her bones that we're going through and all the barium. Yeah. Okay, hold your breath. Expose. Okay, so that wraps up all of the images for the barium enema exam. So then the next thing to do would be to make sure I have towels and make sure I've got the trash can. And I say what we do is we take the bag and unclamp this, and we're going to lower the bag into the trash can so that can help with the barium flowing out. And then I'm going to take this off of the tubing so that the balloon deflates, and that will allow the barium to drain onto the towel here. You may release the and then we would, on the count of 3, we would remove the tip, and that would go directly into the trash can. I would tell my patient, you can roll over, there's a towel under you, go ahead and roll onto the towel. And I'm going to put a stool down so my patient can then safely get up and go to the restroom. Okay. While my patient was, yay! You would do a post-CPAC, which is the same thing as a KUB. So yeah. Cool. Woohoo!
All right, Trudy, you made it through another BE trigger. Woo! We're going to wrap this up and you can put that A in. Oh, yeah. So after doing my spot image, which was a basic KUB, we went right into the right lateral decubitus position, AP projection of the large intestine. The main thing to know about this particular projection is that it's showing the colon full of contrast. And the anatomy that we're going to be really viewing here is going to be the side up for the ascending colon. And when we're in the right lateral decubitus position, that's the medial side. And then the lateral side of the descending colon. It's just looking at the sides that are full of air. You want to make sure that there's no rotation of the patient, and you can check this by looking at, to make sure that the pelvis is symmetrical as well as the ribs, and hopefully you can see, some hints in the vertebral column as well to make sure that there's no rotation there. You're supposed to use a filter or a grid. We did not do that when we filmed ours, but just to state that there. So that's really those are the biggest things about this one, the AP or PA projection. Right, so following that one, we went right into the PA oblique projection, RAO position of the patient, and for this one, what you're really looking to see is that right colic flexure. The RAO position when the patient's in a 35 to 45 degree rotation really helps to reduce the superimposition of that flexure compared to the PA projection. You should also be able to see the ascending portion of the colon and the sigmoid portion of the colon, and that pretty much wraps up this one, the PA oblique projection of the large intestine when the patient is in an RAO position. So the next thing that we went into doing was another PA projection with the patient in the prone position. For this one, it's showing the patient's entire colon. The flexures, both of them, the hepatic and the splenic flexures and the rectum. For hypersplenic patients, you might need 2 image receptors. You want to make sure that you have your patient centered by making sure that the vertebral column is going down the center of the image, and that the descending portion of the colon is also visualized and included. Or for this projection, sometimes you can utilize the Trendelenburg position if you need to. Having the table sort of at a slight incline helps to separate some of the bowels. Sometimes they'll overlap and kind of with the pelvis and each other, and so it's just kind of really helps to kind of spread things out a little bit. So that wraps up the PA projection of the patient's large intestine when they're prone. Then we wanted to throw an angle on there. We did the PA axial projection, same prone position. In this image, it's really showing the rectosigmoid area of the colon the best. You can use a 10 by 12 IR for this. We just kind of kept it simple and used the same IR going through the trigger. So that 30 to 40 degree angle added on really helps to reduce the superimposition of that area. And sometimes you won't get the transverse colon or both flexures in this image, but again, it's just that rectosigmoid area that's the most important. So then from there, I had my patient go into the LAO position. We did the PA oblique projection. This position best shows the left colic flexure and the descending portion of the colon. Use a 14/17 IR for this. You want to make sure that you have the entire colon in this image. This position, again, that 35 to 45 degree rotation of the patient's body really helps to reduce superimposition, but this time of the left colic flexure. And you want to make sure that you have the descending colon included. All right, moving on to the lateral projection. I had my patient in the left lateral position. This is the best projection for showing the rectum and the distal sigmoid portion of the colon. You want to have that rectosigmoid area at the center of your image with no rotation of your patient, making sure to superimpose the hips and both femurs or femora. When the rectosigmoid area or region is the area of interest, you don't need to include the superior portion of the colon. Well, I guess there's not much more I can tell you about it. So that's really all there is about this. This lateral image of the rectum. All right, we're almost to the end of this. So the next projection was the PA projection. My patient was in a left lateral decubitus position. This is really just to show the colon filled with contrast. It's really just showing the side up the best. It's the lateral side of the ascending colon and the medial side of the descending colon. So there's that. You want to make sure that you collimate well. We used a 14/17 IR, which is appropriate. I would want to have the area from the left colic flexure to the rectum. I want to make sure that I have no rotation of the patient, that they are in a true lateral position. And I can check that again by looking at the ribs and the pelvis. This was for a double contrast exam, so it was a double contrast exam, so that means the most important part of the colon is the part that's inflated, filled with air. So you want to make sure that you have good penetration there and not too much, so that you can really visualize structures in that region. Moving on to the next projection, and the last projection was the, what did I just say? This is the AP or PA post-evacuation image, which is just another KB. You're just checking to make sure that all the barium, you got enough of it out and the patient is good to go. Yeah. Alright, thank you for suffering through this video. Kept it as short as I possibly could. Have a good one.
And we don't use this at my site, but that's what this is. And it locks in place, which I just found out.